Hi, everyone. My name is Lilia Lagha. I'm one of the internal medicine trainee in the UK. I work at Frimley Health NHS Foundation Trust, and I'm going to present an interesting case today. I have nothing to declare. So I had this patient who presented to A&E. She was 36 years old, and she had no significant post-medical history, no significant cardiovascular history. She had sudden onset chest discomfort with shortness of breath. She had no other associated symptoms. So there was no dizziness, no syncope, there was no fever and no palpitations. When I examined her, she was pretty stable. She was not needing oxygen. Her saturation was quite good. Her blood pressure was good. Her chest was clear and her heart rate was between 40 to 50 beats per minute. And as you can see on her ECG, there is progressive prolongation of the PR interval. So if you see this cycle here and this one here, you can clearly see a prolongation of the PR interval, and we have a blocked P wave here. Same thing happens again, prolongation of the PR interval and blocked P wave. So this is a wenckebach AV block, otherwise called second degree AV block, Mobitz 1. So we wanted to investigate this further, and then we did multiple investigations. The first thing that we did was an echo. The echo showed a very good ejection fraction in the LV. The ejection fraction was 62%. There was a good RV function. There was a good diastolic function. And the only abnormality on her echo was a quadricuspid aortic valve and a mild aortic regurg. There was no other abnormalities. And this was her echo. So as you can see on the aortic valve here, instead of having 3 cusps, we have 4. Yeah, this is another view. And we have 4 cusps in the aortic valve. The second thing we wanted to do was to exclude a reversible cause of her AV block. So we did many other investigations. We did bloods for her, and 3 levels of her troponin came back normal. Her D-dimer was normal as well. Electrolytes were normal, thyroid function test was normal. We wanted to exclude an autoimmune disease, so we checked for SLE, for rheumatoid arthritis, for systemic sclerosis, and all the investigations came back normal. We wanted also to exclude an infection. We checked for viral infections like HIV, Coxsackie virus, diphtheria, Chagas disease, Lyme disease, and all the results were negative again. And the most important thing about this patient is that she had her symptoms only on admission. So I saw her in ED, and then we transferred her to the cardiology unit. And during her stay in the cardiology unit, she had no recurrence of her symptoms. And she had no episodes of bradycardia, no recurrence of her AV block. So we wanted to do a 24-hour Holter to check her rhythm, basically. And there was, throughout the 24 hours, there was no recurrence of the AV block. We wanted to push things further, and then we did an exercise tolerance test. She was able to reach very good BP and heart rate appropriate to her age, but again, there was no recurrence of her bradycardia, and she was totally asymptomatic. The last investigation that we did was a cardiac MRI, and the reason why we did it is because we wanted to exclude an infiltrative cause of her symptoms and AV block. This includes sarcoidosis and amyloidosis, but the cardiac MRI came back normal. There was no fibrosis, no myocarditis, and no infection. So we have a 36-year-old lady presenting with shortness of breath and chest discomfort, wenckebach AV block on her ECG, and there was basically all the investigations that we did except the echo were normal. So we kept her admitted in the cardiology unit for 4 days, and during her stay, as I said, she had no recurrence of her symptoms. So we decided to discharge her. But before that, we inserted an ALR, a implantable loop recorder, which is going to record what's happening in her heart for quite long period of time. This can go up to 2 years to 3 years. And we are doing regular follow-up in the cardiology outpatient clinic. So my discussion would be on the quadricuspid aortic valve. So as the name suggests, quadricuspid means that we have 4 cusps instead of having 3. Can I just ask, how many of you, have you ever seen any patient with quadricuspid aortic valve before? Yeah, one. Was it just one patient? Just one patient. So it's extremely rare. The frequency is between 0.01 to 0.04, and this is on the basis of echocardiography and autopsy data. And we don't know why patients would get this quadricuspid aortic valve. The reason is not clear, but we have a theory saying that all of this begins basically in the embryological life. So normally we have the truncus arteriosus here, which is going to divide into the pulmonary artery and the aortic valve and the aorta, basically. So we would get 3 swellings, which are going to become the 3 cusps for the aortic valve, and then we are going to get 3 other swellings, which are going to be the 3 cusps for the pulmonary artery, for the pulmonary valve, sorry. However, in patients with quadricuspid aortic valve, there is a problem in the septation of the truncus arteriosus, and instead of having 3 cusps for the aortic valve, we are going to get 4 cusps. I added this picture just to show you how would the quadricuspid aortic look like during a surgery, but my patient had no surgery. So mainly the quadricuspid aortic valve is isolated, but this can sometimes, the quadricuspid aortic valve can sometimes be associated with other structural cardiac abnormalities. The most common one is the aortic regurg. And the explanation is quite simple. So we have 4 cusps. So the coaptation of the 4 cusps is going to be, it's not going to be good coaptation. So this explains the leak and the aortic regurg during diastole. We can have other structural cardiac abnormalities associated with the aortic, with the quadricuspid aortic valve. This can include a ventricular septal defect, atrial septal defect. We can have a patent ductus arteriosus. We can have dilated aortic root, and we can also have some abnormalities in the coronary arteries. The association of quadricuspid aortic valve is, however, extremely rare and is underreported, basically. On the other side, as you all know, wenckebach AV block can be normal in some patients, especially in athletes, because they have a high vagal tone. So they can have a wenckebach AV block, and it doesn't mean that this is pathological. However, whenever we have a patient having a wenckebach AV block and they are symptomatic, or there is a structural cardiac abnormality in this case, we need to take things more seriously. So in the case of my patient, she had both. She had the quadricuspid aortic valve, and then she had the wenckebach AV block. And this was never reported at all. This is basically the first case report on a patient having both a quadricuspid aortic valve and a wenckebach AV block. There was 2 to 3 cases reported about patients who had quadricuspid aortic valve with complete heart block, and one of them is a congenital heart block, congenital complete heart block. You would maybe ask me about the link between the two, between the quadricuspid aortic valve and the wenckebach AV block. The link between the two, again, is unclear. We don't know why, but we think that maybe all of this is related to anatomical factors, just because the aortic valve is close to the AV node. So if there is a congenital problem in the aortic valve, this can cause a problem in the conduction system or the AV node. To conclude, so my case is a patient who had a bradycardia due to wenckebach AV block. The investigations of the wenckebach AV block might just discover a quadricuspid aortic valve. So while both this condition Individually, they are benign, but whenever we have an association between the two, in this case, we need to be more careful and do further investigations. So my take-home message today would be, whenever you have a patient with a wenckebach AV block, don't just assume that this is benign, especially if the patient is symptomatic or if they have a structural heart disease. That's it. Thank you.